بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. مساء الخير جميعا. It is my pleasure to give this talk in the fourth Congress of Arab Thyroid Association. I'm going to talk about thyroid nodule clinical approach according to the ATA guidelines and the Thyroid guidelines, which is the most important two guidelines or way of evaluating thyroid nodule. طيب. So as epidemiology, the thyroid nodule is a very common disease. In my opinion, it is the second after diabetes in the field of endocrinology. So it is very common as a clinical presentation for a referral, and it's also common in population. So in some studies, it reached to 60% of population. And when you perform ultrasound, you'll find more. Even if you palpate a nodule and you do ultrasound, there is 50-50 to find another nodule in the ultrasound other than the one that you palpate. So it's very common in population. It is four-fold higher in female, and the main issue with the thyroid nodule is the presence of malignancy in 5% of them, and also the being toxic to be autonomous nodule in 5 to 10%. This is the old differential diagnosis, old slide from Mazafiri, telling about the differential diagnosis of thyroid nodule from benign, adenoma, cystic, carcinoma, thyroiditis, granulomatous disease, and so on. So as I mentioned before, that's why we care about thyroid nodule. First question, is it malignant or not? And the second question, is it toxic or not? In Saudi Arabia, in our cancer registration, Saudi cancer registration, as you can see here, the thyroid cancer is number one in female between age of 15 to 29, and it's number 3 or 4 in male at the same age. Between 30 to 44, thyroid is the second in female and second in the male after the breast and colorectal. So it's one of the most common cancer in our population. This numbers is also present in the Gulf area, in the Middle East area, Egypt, and also in Western country. Quickly, we are talking about the thyroid initial evaluation. We have to start by history, and the main two factor in history is the family history of having thyroid cancer, either medullary thyroid cancer or in familial papillary thyroid cancer, history of ionized radiation. The age is important, so extreme of age also has higher risk of cancer in a nodule. Male 6, growing nodule, and in history we always ask about the functionality of the thyroid, either hypo or hyperthyroid symptoms and compression symptoms, breathing and swallowing. In the physical examination, we look for also signs of cancer, like firm or hard nodule, fixed nodule, cervical lymph node, lymphadenopathy, functional abnormality, also hypo and hyper signs, hypothyroid signs, and sign of compression by inspection by percussion, looking for thoracic goiter, and also doing the Bamberton sign. The evaluation of the or examination of the thyroid, is it palpable or not? It's usually depend on the iodine status. Where is this patient coming from? So if in iodine repleted area, normally the normal thyroid mass range between 10 to 20 gram. In iodine deficient area, it is up to 35 gram. So the This is the probability of palpation. So after 10 centimeters will be easier to palpate. Larger nodule is easier to palpate. How we initially evaluate? We usually evaluate after the history and physical examination by doing blood work like TSH, thyroid antibody, and plus minus calcitonin, depend on the patient history. Once we do the TSH, high or normal TSH, the next step will be ultrasound. Then when we do the TSH and it's low, we can do the thyroid scan, either iodine or technetium. Once we have a cold nodule, we have to do ultrasound. If it's no cold nodule or all it's hot like in Graves' disease, or there's a toxic nodule in single toxic nodule or multiple toxic nodule, we treat it accordingly. So ultrasound is playing a major role in evaluation of the thyroid nodule. Other things like the technetium and iodine scan, if it's hot or cold. Of course, the cold nodule in technetium or iodine increase the susceptibility of malignancy in the thyroid nodule. The positive PET scan in the neck, especially in the thyroid, and finding this or this finding is coming from the thyroid nodule, is also increase the risk of malignancy. So FDG positive nodule has also higher risk to be cancer. So as I mentioned, the ultrasound play a major role. Why? Because it detect almost all thyroid lesion that we know. It measure the dimension and structure accurately. It evaluate the lymph nodes in the cervical area. One of the famous evaluation tools of thyroid nodules is the ATA, the American Thyroid Association guidelines of evaluating the thyroid nodule, which started a long time ago, and it was updated in 2015. And as all you remember, the finding of or this graph is it's atlas of the thyroid nodule, showing the high risk, intermediate risk, low risk, very low risk, and benign. And we'll discuss all of this. However, this is the old ATA 2009. The other famous tools of evaluating thyroid nodule is the American Thyroid System. And the American Thyroid System also talking about the composition, the echogenicity, the shape of the thyroid nodule, the margin, and the echogenic foci. And based on that, they give points. So let's say, let's take example here. So if it's solid or almost completely solid, we have 2 points, in contrast to 0 point if cystic. The echogenicity, if it's hypoechoic or very hypoechoic, they give 3 points, and hyperechoic, they will give 1 unit. 1 point. In the shape, if it's wider than taller, 0. If taller than wider, it's 3 points. The margin, if there is extrathyroidal extension, they give 3 points. If it's smooth, it gives 0. Echogenicity, if there is punctuated echogenic foci that we use to call it microcalcification, they will give 3 points. And if there is no calcification, they will give 0 points. So they will calculate the number of the points, and they will give thyroid 1, thyroid 2, thyroid 3, thyroid 4 and 5. And if it's going higher point, will increase the suspicion of the thyroid nodule, and they will recommend doing fine needle aspiration. I'm sure you all know about this. However, I just want to remind you about it. One of the things that this 2 old or 2 previous tools of evaluation, they are not talking about lymph nodes. So if there is suspicious lymph node, it's changed the game. So it's a game changer if there is suspicious lymph node. That will increase the risk of thyroid nodule and increase our uh, things to do the to increase our decrease the lower threshold of doing fine needle aspiration. This is example of suspicious lymph nodes. The other thing is the extrathyroidal extension, which is you can tell, okay, it's the extrathyroidal extension was mentioned in the thyroid, but if the presence of the thyroid nodule in the isthmus or in the posterior part wasn't clearly mentioned in the old classification that we talk about. So this is example of a nodule present in the isthmus, and it's open to the muscle, and that also definitely increase the risk. This is a thyroid nodule in the posterior area, which is almost open or near to the recurrent laryngeal nerve. So in ATA 2015, which is was, as we mentioned, the old classification, they talk about the estimated risk of malignancy, and in high suspicious nodule, it's up to 70 to 90%. Then intermediate 10 to 20, which is big variation between the high suspicious and intermediate suspicious, and it's almost the same in the lower suspicious, and very low is 3 and 1%. And they recommend fine needle aspiration if it's more than 1 centimeter. Let's say the difference between the estimated, the ATA 25, which is draft, is not yet published, but they are planning to decrease the percentage of malignancy between from 70 to 90 to almost 50%. The increase the intermediate from 10 to 20 to 20 to 50, and the low suspicious from 5 to 10 to 3 to 20, and very low is the same, and benign is the same. So that's what the ATA 25 going to be. So to decrease the gap between the high suspicious and intermediate suspicious. The 25 ATA was aiming also to classify the non-classified thyroid nodule in 2015. They give recommendation in 25 about the screening of ultrasound. It wasn't there in 15. The eliminate the gap, as I mentioned, between the intermediate and highly suspicious. It introduced patient-central approach and discuss the follow-up recommendation of the of benign and also Bethesda 3 and Bethesda 4. So in 25 as screening, they recommend doing screening for familial non-medullary thyroid cancer, and this is defined by presence of more than 3 first-degree relative of having papillary thyroid cancer. You can then screen the rest of the family. And also the B10 HTS Cowden syndrome, if it's there, you can also screen the family and at the time of the diagnosis. So as I mentioned, this is 2015. In 2025, they are planning to have a different approach, which is they divide the nodule to solid, cystic, or cannot be a cyst. So this is the composition. So solid, more than 90% of solid. Cystic, it's more than 10% of cyst is called. If there is 10% of cystic area, they will call it cystic or cannot be a cyst. If the solid, if there is solid nodule, so they divide it to markedly hypoechoic, as dark as strap muscle, or hypoechoic, not markedly hypoechoic, but it is hypoechoic, or isoechoic or hyperechoic, they put it in one category. The 4 solid nodule suspicious feature, which is SSF, suspicious solid suspicious feature, which is irregular margin or non-uniform halo, intrasolid punctated echogenicity, which is the microcalcification, taller than wider in shape, and macro calcification. So this is macro calcification, and this is intrasolid punctuated echogenic foci. So this 4 is called the SSF, and this increase the risk of cancer. So this is an example of anechoic, hyperechoic, isoechoic, and hypoechoic. So this is the example of wider than taller. This is example of smooth margin, ill-defined, irregular, lobulated. And this is also talking about extrathyroidal extension. And in the solid, they talk about the high suspicious, markedly hypoechoic. And so the highly suspicious in the new guidelines called markedly hypoechoic and one suspicious feature, or hypoechoic with 2 suspicious features. The intermediate is markedly hypoechoic, no suspicious feature, or hypoechoic with 1 suspicious feature, or and hyper and 1 suspicious feature. Low suspicion is hypo or iso or hyperechoic with no suspicious feature or one of the 4. And this is the table that's showing the thing that we are talking about in regarding the highly suspicious. Partially cystic can be highly suspicious if there is solid component that have acute angle or protrusion or speculated interface of the cystic area or intrasolid punctuated like microcalcification or macrocalcification. The partially cystic can be only low suspicious if there is no other high risk feature. So in the cystic area, if it's partially cystic, as we talk about, the sponge form or a solid component that have no high risk, or entirely cystic. And in this regard, we can see this is the sponge form, this is the mixed cystic, and in the macro or sponge form, we can say it's low suspicious if it's more than 1 macrocalcification or regular outer nodule margin or irregular halo. At very low suspicions, if there is solid component, are all sponge form or microcystic and no other suspicious solid suspicious feature. The cannot be assessed is depend on the the egg shield. So if it's highly suspicious, if there is peripheral calcification protrusion, so breaking of the egg shield, or intermediate if there is irregular peripheral calcification, or low suspicious if it's completely covered and with egg shield. As I mentioned, the estimation of the risk of malignancy was reduced in highly suspicious and increase in intermediate suspicious, and it will be almost the same in the other 3 categories. So this is the cutoff of doing the thyroid nodule, which will be proposed in 25, and they propose 1 centimeter to 1.5 in the highly suspicious, intermediate 1 to 2, low suspicious 1.5 to 2.5, very low suspicious or benign is not indicated. And they put FNA size cutoff, and they also give a strong recommendation for the highly suspicious and conditional in intermediate and low suspicious. So it's almost the same. However, they give 1.5. The thyroid, as I mentioned before, it doesn't have all the feature in the coming ATA guidelines. In 25, they also add some of the decision or patient-centric decision making. So in age elderly, they favor larger size cutoff. So the threshold is higher in fine needle aspiration, so they avoid doing fine needle aspiration in elderly. They avoid doing it with patients with comorbidity. And in the other hand, they favor a smaller size cutoff for doing thyroid fine needle aspiration or lower the threshold of fine needle aspiration in a patient with personal risk factor for thyroid cancer, evidence of sonographic pattern of risk of malignancy, the FDG positivity, symptoms attributed to thyroid nodule, and nodular location. So nodule location, as I mentioned before, isthmus and posterior, it's either because of the isthmus, because of the invasion to the muscle or to the trachea, or the posterior in the recurrent laryngeal nerve. They give or they favor smaller size for fine needle aspiration. This is not in the thyroid. I'm going to pass the European thyroid. I was planning to talk about it, but because of the time, I may just escape this. In the Canadian fine needle aspiration, I like it because they just all give only three categories: the high, low, or intermediate. And as we talk about the suspicious lymph node, I'm going to pass this because I already mentioned it. I may just take the last minute to talk about my approach in the thyroid clinic, in my thyroid nodule clinic. And I usually ask 5 questions. The question number 1, is the patient surgically candidate for doing surgery? If the patient is not candidate for surgery, this is end of it. I'm not going to do fine needle aspiration, whatever is there. So if he is candidate for surgery, I will go for lymph node. If the lymph node is there, I will do the fine needle aspiration regardless of anything. I'm not looking to the thyroid node. If there is suspicious lymph node, I will do the biopsy for the lymph node and any thyroid nodule there, regardless of its shape. If there is no suspicious lymph node, I will go for extrathyroidal extension. Exactly looking for the trachea and the area of the recurrent laryngeal nerve, and the third one is the surrounding muscle. So if there is any suspicious of extrathyroidal extension, I will do fine needle aspiration regardless of anything, regardless of the size, even regardless of the shape of the nodule. If there is no extrathyroidal extension, I will go to the size. If the size is less than 1 centimeter, I am not going to do fine needle aspiration whatsoever. What is the how the thyroid look like? If the thyroid nodule is more than 1 centimeter, then I will go to number 5 question, which is there in taller than wider, if it's irregular border, if there is hypoechogenicity, if there is microcalcification. If any one of them are present, I will do the fine needle aspiration more than 1 centimeter or 1.5 centimeter. If I am planning to do any form of therapeutic procedure like alcohol injection, if I'm going to do microwave ablation or radio frequency ablation, I will biopsy all the nodule, even if it's low risk, before doing the procedure. So this is my 5 question in my clinic, and this is the same protocol that I talked about. Once you have the fine needle aspiration, this is one of the most accurate, most effective method in diagnosis and evaluation thyroid nodule. I don't have enough time to talk about the molecular testing or the fine needle aspiration result, which I think there will be another lecture which will be done by one of my colleagues that I am sure they will provide you with better information than me. Thank you very much, and I appreciate your time.